Hi everybody, my name is Dr. Schnorr, one of the reproductive endocrinologists here at Coastal Fertility, and I am glad to be with you, and we are here today to talk about a very common issue, which is called Polycystic Ovarian Syndrome. And so we're going to spend some time today. I have Holly with me, who's been gracious enough to take any of your questions. So if you have any questions along the way about what we're doing, what I would ask you to do is just ask them right in the middle of the talk. And if it's pertinent to what we're talking about at the time, then we'll actually go over that question. If it's something we're going to address later on, I'll hold that question and we'll address it a little bit towards the end. So a little background about what a reproductive endocrinologist is. I'm an OBGYN trained doctor. That was 4 years of OBGYN training. I happen to personally do training at the University of Virginia. And then I did a 3-year fellowship in reproductive endocrinology. I did that at the Jones Institute, which is in Norfolk, Virginia. Very special place in the world of IVF and in vitro fertilization. Had the first IVF baby in the world through gonadotropins, which is the hormones. Actually, turns out the first baby in the world from IVF came from natural cycles, where a bunch of natural cycles were done. Was very ineffective, had low pregnancy rates, and really at the Jones Institute is where they decided that they could use medications to help make eggs, and then through that, get more eggs, get more embryos, and better pregnancy rates. Interestingly, at that time, pregnancy rates might have been 5% to 10% per IVF cycle. Nowadays, pregnancy rates are 70% or so per one embryo transfer, just depending on, egg age and quality and some of those things. I know we're here to talk about polycystic ovarian syndrome. Polycystic ovarian syndrome is a disorder. That is not a new disorder. I think when we all think about polycystic ovarian syndrome, we think that it's a relatively newer problem. Polycystic ovarian syndrome was reported back before 300 BC, with the first female statue that was ever described and found was found to have centripetal obesity and found to have some stuff around the face, which was described as hirsutism, which is hair growth on the face, and it had some text below it that showed that this woman had infertility. So they were really describing polycystic ovarian syndrome. And since that time, polycystic ovarian syndrome has continued. When you look at polycystic ovarian syndrome, you find that the incidence is the same in America as it might be, for example, in Italy or France and in other countries. So it's not just an American problem, it's a worldwide problem. Polycystic ovarian syndrome is a syndrome, and that actually gives it controversy. Syndrome means that there is laboratory component and a clinical component, and they need to match each other. And so it's not as simple as drawing one blood level and knowing what the diagnosis is. You really need to see a physician to see if there's the clinical component and see if it matches with the laboratory component. Adding a little bit of fuel to the controversy and fire is there's multiple different guidelines from multiple different societies, some being international societies, some being national societies, and they don't fully agree with each other. And so you'll often get some conflicting reports, even though you're talking to a specialist, some might slightly disagree with each other. I'm going to talk with you a little bit more about the American guidelines and my personal belief about polycystic ovarian syndrome, but that's not to say that there aren't maybe some slight differences and nuances to it. Polycystic ovarian syndrome is a disorder that, as a hallmark, really needs to have irregular menstrual cycles. Irregular menstrual cycles to us mean that the menstrual cycles are consistently greater than 35 days apart. I am a believer that if you're in a room full of patients and women and you ask, are your cycles irregular, almost every woman will raise their hand. And what a lot of those are mentioning is that some days it's 28 days apart, some months, and some months it's 29 days apart, and it varies. Well, if it varies between 25 and 35 days apart, that's really within the range of normal. If it's consistently greater than 35 days apart, that starts getting to that menstrual cycle irregularity that we get concerned about. And the reason we get concerned about menstrual cycle irregularity is that irregular cycles means irregular ovulation, and irregular ovulation decreases the number of chances of pregnancies you have in any particular month or year. So cycles greater than 35 days apart is the first criteria. The second criteria is you generally need some signs of elevated male hormones. The primary male hormone is testosterone. Women have testosterone just like men have testosterone. Men have testosterone levels of 300 and 400 and 500 would be common male testosterones. Women's testosterone levels are generally going to be 10, 15, 20 might be a woman's testosterone. Some actually have lower than 10. Generally, women with polycystic ovarian syndrome have elevations in either the free or total testosterone levels, and we start seeing levels of maybe 30 or 40 or 50. It's not uncommon to see PCOS women kind of 80, 90 for testosterone levels. If the testosterone level is much greater than 120, we start thinking there might be some other things that are going on. The other measurement would be free testosterone. Sometimes your total testosterone is normal, but your free testosterone is elevated. That's due to something called sex hormone binding globulin, which can make it so that your free testosterone level gets elevated. And so really a free testosterone much greater than 3 to 4 would be something that we would think about. The other thing, instead of measuring testosterone, is you can just see if you have hair growth problems. Again, if you have 100 female patients in the room and you ask do any of you have abnormal hair growth, all 100 will raise their hand, and 95 out of the 100 will point to that one little hair here or the one little hair here. That actually is normal. But, there can be a contingent of patients who have, kind of male pattern hair growth on their where they get sideburns, some actually using shaving, waxing, and other things to kind of deal with that. And so that would be also clinical hirsutism, which is elevations in male hormone levels. And so really to have PCOS as a diagnosis, you need consistently irregular menstrual cycles, and you then need elevated androgen levels, testosterone primarily, and we generally can see that clinically or measured in the bloodstream. Now, some might say, yes, but some of the guidelines say, you count the number of eggs on the ovaries, and that can tell you. And I think that tells you if you have polycystic ovaries. Poly in Latin means many, so polycystic means many cysts in the ovary. So polycystic ovaries, frankly, is something that every father wants their daughter to have, and the reason they want their daughter to have is because they want grandkids. And if you have polycystic ovaries, not the syndrome, but ovaries, means you have lots of eggs in your ovary and you generally have healthy ovaries, and that's a good thing. So I want all of my patients to have polycystic ovaries. What I don't want them to do is have polycystic ovarian syndrome. The syndrome is when you have the irregular menstrual cycles and hirsutism associated with it. So there are some international guidelines that use egg count with it. They then combine the egg count with, do you have irregular cycles, do you have elevated androgens? I think it actually confuses the diagnosis, and in extreme cases can mistake the diagnosis for things like hypothalamic and amenorrhea, which can confuse it a little bit. So I stick with the American guidelines, which is irregular cycles greater than 35 days apart and signs of male hormone excess. So what's the cause? What caused all this? Well, there's been a lot of research on this. We find a common association between polycystic ovarian syndrome and diabetes. Diabetes being primarily type 2 diabetes, which is a diabetes in which your insulin levels are high because you have insulin resistance in your body. So you have insulin receptors in your body that actually don't recognize insulin quite as well, and therefore the mechanism of insulin action to lower your sugar levels, called glucose, doesn't work as well, which then elevates your insulin levels, and the elevated insulin levels cause you to have elevated male hormone levels. And so we've done more research into that and found that this is probably genetic, that you inherit an abnormal insulin receptor from your mom or your dad. That receptor then makes it so that it doesn't get stimulated well by insulin. Your insulin level rises through the thecal cells within your ovary. Your ovary then makes more testosterone because of that insulin elevation. And then the testosterone changes the secretion of FSH and LH out of the brain, which makes it so you don't make enough FSH and you make too much LH, and that combination makes it so you don't ovulate. So again, genetically inherited. Yes, your dad can be the cause. How could your dad have PCOS? Well, he didn't have PCOS, but he had insulin resistance, often manifested by hypertension, obesity, centripetal obesity, male pattern balding. Those are common symptoms of insulin resistance in men that can pass that down to their children, their daughters specifically. So, what to do? Well, often this insulin resistance causes weight problems. And if you have weight problems, that means your adipose tissue is going up. And by definition, adipose tissue is insulin resistant. So as you gain weight, you're getting more insulin resistance because you're getting more adipose tissue. Plus you inherited an abnormal insulin receptor, making it even worse. So those two compound each other. So the board exam answer, patients don't like this answer, but the board exam answer is first work on weight reduction, right? So if you work on lowering your weight, your total body insulin resistance goes down, and it will help you conceive. And I've had many patients conceive simply by losing weight. We're not here to say we want you to have a normal body weight. We're here to say that for every 5 pounds you lose, you'll have a significant improvement in your pregnancy rate. We also know that lowering weight actually not only improves your pregnancy rate, but lowers your miscarriage risk. And we know that by lowering weight, you have lower pregnancy complications because you're now thinner. And so it improves things at 3 or 4 different levels. Weight reduction would be the first thing to do. So whenever I say that, the patient asks, what medication can she take to lose weight? What diet does she need? And honestly, I'm kind of a moderation kind of person. I think you need lifestyle intervention. I think you need to lower portion sizes. I think you need to lower caloric density and eat less fatty foods, eat healthier foods. People on plant-based diets or people who get closer to plant-based diets do much better. So I think there just needs to be a lifestyle intervention and change that needs to continue forward. A grapefruit-only diet or a bagel-only diet or whatever diet people can make up, it's not the answer. That's not the long-term solution. And again, we're not asking for the weight to get down to normal weight. As long as it took you to gain the weight, it's going to take you probably half as long at least to lose the weight and get it down. For people with a body mass index of greater than 45, I think it's a reasonable discussion to start talking about the role bariatric surgery and other things may play to help you accelerate that weight reduction. There are lots of studies in our field now talking about the benefits of bariatric surgery and lowering weight and causing and resulting in conceptions and healthier pregnancies. So I think that's a great way of going about doing it. So weight reduction, number one. Probably a third of all PCOS patients don't have weight problems. So it is true that there are what we call lean PCOS patients. Weight reduction is not the answer. If you have a normal weight and PCOS, weight reduction won't help you any. But if you have a body mass index of, say, greater than 30, I think weight reduction is going to be a benefit. By the way, body mass index is a compilation of your height and your weight together. It's trying to be fair for those people who are taller that says you can weigh more if you're taller. But likewise, if you're shorter, you should be weighing a little bit less. There are calculators on Google that you can go to that will calculate your body mass index for you. Second thing we talk about is controversial, but there can be roles for insulin sensitizing agents, diabetic medications. These patients with PCOS have a risk of being diabetic at the time of diagnosis of around 10 to 20%. But even if you're not a diabetic medications can lower the insulin levels, lower the insulin resistance, and can play a role of helping. Metformin is the one that's typically used. It's pregnancy safe. It does result in improved pregnancy rates. It's not a landslide victory. You don't take it and double your pregnancy rate. But if your pregnancy rate on your own is 3% and you're taking metformin, it might be 5%. But as a fertility doctor, we take every 2 or 3% we can get. And so happy to take an extra 2 or 3% benefit with metformin. Now, bad news for metformin is when you take it, its job is to block glucose from absorbing out of your GI tract. And so if you take metformin, you're going to be leaving glucose in your GI tract, and bacteria love that. And so the bad news is it can give you diarrhea, it can give you gas production. If you take a Snickers bar and eat a metformin at the same time, it's going to be a bad day for you and your partner. And so the recommendation would be kind of moderate your diet a little bit. Metformin can be a benefit for you. And so I generally do use some metformin. It helps people lose weight, sometimes metformin, so that can be a little benefit. So sometimes the way to start first is make sure there's not another problem. Check the sperm count, check the tubes, check other things. If PCOS is the problem, metformin, weight reduction, and then once you get into a little better weight, then start some form of treatment. What would that form of treatment be? Well, generally the form of treatment is to give you medications, either by mouth or injections, or a combination of mouth and injections, and with that help you make eggs within your ovary. The goal is to make 1 to 2 eggs. We don't want to make too many eggs because that makes too many babies. Help you make 1 to 2 eggs. We do ultrasound monitoring to make sure it's done safely. We figure out when you're ovulating. and then either let you try to get pregnant on your own with intercourse, or there can be a pregnancy rate advantage to concentrating the sperm and putting the sperm into the top of the uterus when you're ovulating. We tend to prefer the intrauterine insemination because that in and of itself seems to double the pregnancy rate. So by helping you make more than one egg or one to two eggs, we tend to get a pregnancy rate of maybe 10% by concentrating the sperm and putting it into the uterus at the time of ovulation. Another 10% bump in the pregnancy rate. Pregnancy rates with that approach tend to be about 20% per try. What's the cost? Well, we use oral medicines and we add it to injectable medicines to keep the cost down. Medication costs, I'm guessing, about $300. There will be a couple of ultrasounds along the way to make sure it's being done safely, and that might be another $400 or $500. We then concentrate the sperm and put it into the uterus at the end, probably another $700. So you're kind of in the $1,500 to $1,800 per month range, with typically a 20% chance of pregnancy per try. Once you are pregnant, we generally continue the metformin until about 12 weeks of pregnancy, at which time we stop it. We hand you back to your OBGYN around 9 weeks of pregnancy, so they start caring for you then. Your pregnancy is just as healthy as other women, your own weight, kind of moving forward. And I do say that carefully, that, if you have a higher body mass index, you are at increased risk for pregnancy complications. That's not because of the fertility treatment per se, it's just because of the weight challenges can have on pregnancy. So what about if you have PCOS and you're not trying to get pregnant? That's common. Again, same diagnostic criteria. If you're not trying to get pregnant, then that means we should get you on birth control pills so you don't get pregnant, number one. And number two is birth control pills have a wonderful way of giving you regular menstrual cycles, which has a way of protecting the uterus. The birth control pills have progesterone in them. The progesterone lowers endometrial cancer rates. Birth control pills have been shown to lower ovarian cancer rates, and so that becomes a benefit. Birth control pills are probably neutral on weight, meaning you don't lose weight on birth control pills, but you don't tend to gain weight on birth control pills. As soon as I say that, generally about 3 out of 4 patients argue with me about the birth control pills gaining weight. But there's some very classic studies in our field that show that if you take two groups of patients, you put one on a placebo and you put the other on the birth control pill and you watch over time, both gain weight over time. So it's not that the birth control pill is worse or than the placebo. We all tend to gain weight over time, but birth control pills in and of themselves generally don't cause increased adipose tissue or other problems. So last thing to talk about is that women with PCOS are at increased risk for what we call dyslipidemia. That's abnormalities of your lipid levels, which can clog up your heart and cause heart disease and other problems. There have been people in the past who have advocated for metformin or other things like that to help with dyslipidemia. I think that's the wrong approach. Metformin might be a slight benefit, but more importantly, statins are a much bigger benefit. The cardiologists have discovered statins probably 15 years ago. It's been revolutionary in protecting the heart. And so if you're at increased risk for heart disease for whatever reason, including PCOS, you're much better being on a statin agent than you would be on metformin. So if you came to me and said, Schnorr, I got PCOS, what am I going to do? I don't want to get pregnant. I'd say birth control pill. Let's get you to an internist. Let's make sure you don't have diabetes now. Let's make sure your heart healthy. And then they would prescribe statins or do other things along the way. So that's kind of a little overview of PCOS. I know there have been some questions coming in, and I look forward to going over some of those with you.
Okay, I've got one from Casey, and it might be about what you just talked about. Is Provera a good option for helping keeping a cycle regular?
Great. So Casey, great question. What I mentioned is that people who have PCOS are not having regular periods. They do increase the increased risk of having endometrial cancer. Birth control pills regulate that because it's got progesterone in it. It's very reasonable, instead of birth control pills, just to take Provera. Provera will give you a period. I think a woman should have a period at least once every 3 months to protect the uterus. I think that would be good. But remember, that's not going to be contraceptive. So if you're that patient with PCOS who doesn't want to get pregnant, Provera is not going to help you if you're having intercourse. That's where a birth control pill would come in. If you're infertile and having irregular menstrual cycles, you'll have periods when we give you medicine to make eggs, and that will fix that. So I think it's a good question. Provera probably taken every quarter if you're not having periods.
Okay, next question. Do you find that PCOS patients with middle range prolactin levels have had good success with letrozole or a trigger shot method of treatment?
Yeah. So the question is PCOS with prolactin levels. Prolactin levels are slightly elevated for women with PCOS. A normal prolactin level is generally kind of under 20, but it's not uncommon to see PCOS with a level of 26, 30, 32, 35. That's generally not the cause of the irregular cycles. I'm not sure that the prolactin needs to be treated. I generally don't treat low levels like that unless there's other symptoms that need to be addressed. And patients do respond well to letrozole, Clomid, or injectable medications with mild elevations in the prolactin.
Okay, if you have normal cycles but still have high levels of male hormones, facial hair, could you possibly have PCOS?
Yeah, so good question. It kind of goes back to the definitions a little bit. And so if you have elevations in androgen levels and hirsutism, could you have PCOS even if you have irregular cycles? Not by the American definition. It would fit into the Rotterdam criteria, which is the European definition, if you had a high number of eggs in your ovary. The question that I would ask is, what would be the mechanism of infertility? Because you're having regular periods, which means you're having regular ovulation. And so that's where I get into a quandary with the European guidelines, is that you can also be having PCOS as a diagnosis, but there would be no mechanism for you to have infertility through PCOS because you're having regular periods.
Okay. How often do individuals with PCOS have high fertility indicators on ovulation tests, but don't display peak results?
Yeah.
So estrogen peak without LH peak. Is it still possible to get pregnant without peak results?
Yes. So the answer is you're doing monitoring to figure out when you ovulate, and your monitoring is giving you what we call a false positive, meaning that you're getting positives, but it's not really a true positive. And that's because your LH levels generally rise when you have PCOS, which then falsely triggers your KIT. And estrogen levels maintain a moderate elevation. So I think that's going to be a challenge for some patients with PCOS, that they can't find ovulation. And the answer is pretty simple. It's regular intercourse. And so we think that sometimes ovulation predictor kits cause more harm than good. They're expensive. They're stressful. They make it so you're having intercourse when you feel like you get time constraints. You got to do it right away. And we know that sperm lives in the reproductive tract for 2 to 3 days. And so we would advocate as reproductive endocrinologists just to have intercourse every third day. And that would give you adequate exposure to sperm. It wouldn't matter when you ovulate. You wouldn't have to go through all the kits. Particularly beneficial if you have a lot of false positive kits like you're describing.
Is IUI typically recommended over IVF for PCOS patients? And if so, could you explain why?
Yeah. So IUI versus IVF depends on how many different diagnoses we have. If we only have an ovulatory problem, then we just got to fix ovulation. And personally, I start with IUI. Now, if you do 3 IUI cycles and it doesn't work, then I think we probably have something else we're dealing with, and then we move forward with IVF. But before we do IUI, we want to understand what's the sperm count? Are the tubes open and working? Are there uterine problems or other things we need to address? We feel horrible. I would feel horrible if I thought you had PCOS, I put you through 3 IUI cycles, and later found out your tubes are blocked and forgot to check them, right? I mean, that would be terrible for everybody involved. So we're a center and a specialty that just double checks everything up front, just to make sure we know exactly what we're dealing with. Because again, about 20% of all couples have more than one diagnosis of infertility, and we want to be able to fix all the problems at the same time. So if you came in with PCOS and low sperm count, then IVF would be a better solution for you. Same with if you had PCOS, maybe blocked fallopian tubes.
I think that's it.
Okay.
Yeah.
Well, I hope everybody is doing well. This is a nice venue to meet with everybody. Again, I'm at Coastal Fertility. We have offices throughout the state of South Carolina and Savannah. Our main office is in Mount Pleasant. We have an office in Somerville, which is in the Nexton area. We have an office in Lexington. We have an office in Myrtle Beach and an office in Savannah. I want to thank Holly for being here to help us with all this, for Facebook being here to help us with all that. Hope everybody stays safe during the upcoming, what's likely to be just a tropical storm coming through the area, and look forward to seeing everybody soon. We'll see you later. Bye-bye.